Welcome, everyone. We're so glad to have everyone with us today. I want to thank you for joining us for today's discussion on artificial intelligence in the Black community with a focus on colorectal cancer and screening. My name is Shaltana Edwards, and I serve as the Program Director for Agape Strategic Solutions of Maryland. I have a foundational background in biology and public health, and my work focuses on leading diverse programs that advance health equity, community engagement, and access to care. I'm excited to help guide today's conversation as we explore the role of AI in healthcare and its potential to improve colorectal cancer screening in our communities. For context, AI, accelerated by powerful processing machines, also known as machine learning, is rapidly growing and shaping healthcare ecosystems. However, people in harder to reach communities are not always included in conversations about how these technologies are developed or applied. So today we'll explore this more deeply, specifically discussing how AI is being integrated into healthcare and how it intersects with clinical workflows and what it could mean for improving colorectal cancer screening and early cancer detection. We'll be using a moderated round robin format for today's discussion. There will be 6 core questions guiding our panelist conversation, along with 3 audience polls throughout the session. If time permits, we will have an opportunity to answer audience questions at the end. And we also encourage you to engage in the chat as we go, as your insights and comments help inform future conversations and topics we explore in this series. So now, without further ado, let's introduce you to this great panel, beginning with Dr. Covington. Please share your name, your role, and how your work connects to healthcare industry, research technologies, and community engagement.
A great day, and thank you, Shatana. My name is Dr. Melva Covington. I am the Managing Director and founder of Agape Strategic Solutions of Maryland. I'm also the co-founder with Ms. Tamara Allen of People Empowering People for Inclusion Now. The exclamation in the middle part of the name says that we're urgent about the issues that we face. Our core competencies rely not only in conducting research and engagement, but really scaling that using digital technologies. My background is in population health, maternal child health, public health. I spent 25 years in the pharmaceutical industry, but I'm also a strategic thinker and a patient advocate. So I'm delighted to be here today and to partner with these giants in the industry to have this conversation today. Thank you.
Thank you, Dr. Covington. We're glad to have you today. Next, Dr. Manley.
Good afternoon. Thank you for having me on. I'm Dr. Eugene Manley Jr., and I'm the founder and CEO of the STEM and Cancer Health Equity or SHEC Foundation and Innovation for Impact Consulting, LLC. At a high level, I work to increase STEM access and exposure for diverse scholars, work to increase health literacy and health advocacy for diverse and underserved populations navigating cancer, and do a lot of work of addressing lung cancer disparities. So I do a lot of intersectional work in doing community outreach programs, educational programs, and content to help alleviate barriers, improve awareness, and increase the ability to advocate for care that you are entitled to. And I will turn it back over to you.
Thank you, Dr. Manley, and thank you for joining us today. And last but certainly not least, Ms. Dockery.
Hello, thank you all for having me. I am Martha Dockery, the founder and CEO of Superior Clinical Research, and I've spent 20 plus years in the industry, and my work is rooted in one simple belief: research should reflect the people it's meant to serve. And whether it's through education, outreach, or high quality study execution, our goal at Superior is to make sure clinical research isn't something people feel excluded from, but rather feeling a part of. So we like to say clinical boots with community roots.
That sounds perfect. Thank you, Ms. Dockery. And thank you for all those introductions and for sharing a bit about the work you each bring to this conversation. To start us off, I'd like to ground our discussion in everyday experience before we move to healthcare specifically. So, as we know, AI is already embedded in many aspects of everyday life. While many people recognize AI as a concept, they may not recognize that it's making decisions about them in very high stakes places. So, from your perspectives, how is artificial intelligence showing up in everyday life within diverse communities, particularly in Black communities? And what has been the general level of awareness, understanding, or conversation about how these technologies influence daily experience and opportunities? And Dr. Manley, we'll start with you.
Thank you for asking this very nice first question to set up the rest of the show. At its basic level, AI is an algorithm that uses data that is already out there or data that is acquired to predict how people may act, behave, respond, buy, sell, market, etc. So it's already all around us, even before we were calling it AI. And I think a lot of people underestimate the impact that AI has already had in our daily lives. So I'll just give some examples and then the other two speakers will follow up with other examples. So we think about this in healthcare when we look about insurance claims, prior authorizations, speech to text, hospital predictors of disease risk. You think about banking and housing, whether it's credit scores, mortgages, lending. In homes, we have home thermostats, security cameras, robot vacuums, smart speakers, and then even just the biggest thing that a lot of people use are online, Netflix, YouTube, Hulu, which is no longer going to be in function soon, but they literally look at what you see and view and then try to predict things that you will like to see. And so you're always getting stuff thrown at you.
Thank you, Dr. Manley. Ms. Dockery, adding to that, from your perspective, what are you seeing in terms of how people encounter AI in their everyday lives and how they can approach it?
So AI is everywhere, like Dr. Manley said. I think I don't need to even go down the list again, but we think about it in jobs, right? With resume creation. But it doesn't have a human element. So one of the things we can do is name it, right? Name that it is AI. Learn enough to ask better questions. Get in the rooms, right? Sit in those school boards and seeing what people are doing with it. Connect with organizations that's already doing the work. The Justice League, Color of Change, local digital groups. AI is here, and the goal is to be informed so you can be accepting it and being a part of it.
Thank you, Ms. Dockery, especially for naming those organizations that we as, the community and general public can really get involved in to learn more. Dr. Covington, drawing on your professional and clinical experience, can you expound on what we've already heard so far?
And I agree with, again, what my colleagues have said. Let me just say that it is expansive. It's like the gospel truths, and I express I put like in quotes, but there, when we talk about AI, we're not only thinking about artificial intelligence, as has just been explained by my colleagues, but we're also talking about machine learning. And machine learning is using, again, these powerful computing systems, if you will, that will quickly process these algorithms to do input tasks. So it helps us to not only learn, but also learn quicker. The other thing that we're talking about is deep learning. Right? Deep learning, it uses ML, if you will, and it's multi-layered. It uses these neural networks, just like your brain works or your brain functions, to really make complex decisions. It mimics human behavior. It mimics human functions, if you will, to a certain extent. So why I'm saying this is that it is embedded in anything, again, like the gospel truth. It's present in our daily lives. It's present in how we communicate, or at minimum, who we're supposed to be. It's present, and the information that we get may or may not be real. And so we have to be very careful when we talk about AI, when we think about its use and its application in day-to-day lives, and particularly in healthcare.
Thank you, Dr. Covington. So what we're hearing is that AI is already present in many parts of everyday life, often in ways that people may not immediately recognize. So building on that, let's shift our focus specifically to healthcare, because this is one area where AI is advancing rapidly and has the potential to influence both patient care and health outcomes. So my next question is, where are we already seeing artificial intelligence being used in healthcare today? And from your perspective, are these developments creating more opportunities, more concerns, or a mix of both?
I think that's me. So AI is already here, right? We've talked about it. But if we drill into what's already happening in the healthcare space, it's diagnosing diseases, it's predicting risk, it's managing those chronic conditions, assisting with surgeries, and handling the administrative work. In the right hands, it can catch things earlier and reach underserved communities and take the pressure off overworked or underpaid providers, right? But here's the tension. And everybody know me, I'm the but person. I should be but but here we're gonna talk about the but. The communities the most failed by healthcare technology historically are the ones at the most risk of being failed by AI healthcare. And so why? Many systems are trained on data that underrepresents the Black patients. Widely used algorithms that Dr. Covington talked about was found to underestimate how sick Black patients really were, directing less care to the people who need it the most. And let's talk about some skin diagnostic tools. They're trained on lighter skin tones are and perform worse on darker skins. And we can see it here now. Like I'm always like, am I too dark in the camera? And I think my camera is using AI right to brighten it up. Pain assessments, tools have reflect the same biases that already exist in clinical care. So that's not changing. But I also want to call out people don't even know that AI is sometimes involved in their care. So here's the bottom line for everybody. Technology has the real potential. But the problem is who's building it, what's in the data, what is it trained on, and whether there's any accountability when it goes wrong.
Exactly. Thank you, Ms. Dockery. And I think we had a comment in the chat that was reinforcing what you were saying, right? About how if AI is not, if it's biased when it's trained, the results are going to be biased, the outcomes are going to be biased. And thank you again for pointing out the opportunities and the concerns, because we like to talk about opportunities, but we can't ignore the concerns that are there as well. Dr. Covington, building on that point, from your perspective and research perspective, how should we be thinking about the use of artificial intelligence in healthcare when it comes to the historical context of trust and the data these systems are built on, again, particularly within Black communities?
So thank you for that. The use of AI and how it learns and how it's scaled is of tremendous importance in the healthcare community and particularly in the Black community. I just want to frame this issue. We're talking about the Black community, but the Black community is not monolithic. Right? It's a highly diverse, multifaceted people. And I use the term, or we're using the term, I believe, to really talk about people who potentially are in the Americas who are here as a result of African ancestry, right? And so we understand the history of that ancestry in the U.S. for over 200 years as it relates to enslavement. Right. So that experience, as we can think about it, has a certain amount of expectations, or it has an impact. And so we talk about it through a lens of historical, social, and perhaps even biological experiences that can impact people's health and their health outcomes, particularly for the African Americans that may be impactful for our purposes today. Right. So therefore, it's important for us to talk about the use of AI and the impact of the technologies in the communities, because we have to understand a few key questions, right? One is, what technology is being offered, right? And how is it being offered? These are powerful tools and systematic processes, if you will. So I always start by asking a question. What is the data source upon which this either tool or this device or this process has been built? How has it been trained? How has it been validated? So people have to really understand that as we begin to really be more embedded in AI technologies or other kinds of digital technology. So we want to inform people to ask that questions, or at least think about that question. Those questions. What is good from the start? Is garbage in, garbage out, right? So clarify the question, if you will, within communities, and always ask about the data sources upon which either a tool or device is built, trained, or validated. I'll stop there, because if you know me, you know I can go on. But for the sake of the other colleagues in the room, I'm going to stop right there.
Thank you, Dr. Covington. And you'll be getting into it even deeper later in this conversation, but I want to thank you for emphasizing the importance of understanding how these systems are built and the data used to train them. Dr. Manley, I'd like to bring you into the conversation. From your perspective, how are you seeing AI integrated into healthcare innovation and research, and what opportunities or challenges stand out to you?
Thanks. So I'll follow up some of their stuff with more general stuff and then some specific examples. So we know that AI is really being used to predict or funnel patients into a risk category, which then may determine if they get extra interventions or lose these interventions. We know we are really seeing it in robotic assisted surgeries. That's really a great use case scenario because you can reduce scarring. We've seen it used in voice to text to help doctors do documentation, but there's just reports. I think there was something just came out that said, but doctors are only picking up maybe 18 minutes overall just for using voice. So it's not really moving the needle. 18 minutes in a whole year, that is not a lot of time that's being saved. We know in particular in lung cancer, AI is being used to either look at lung cancer nodules or predict when patients with a nodule may develop lung cancer. And there's one that shows up to 5 years in advance of when a scan shows a nodule when a person might have lung cancer. But if we think about the challenges of the research, the biggest issue is that much of our data and our basic research samples are based on cell lines and samples from European populations. So we have a lot of genomic databases that are used as reference genomes, but this determines then what genes are expressed and what's the baseline. And then this often underrepresents the diverse and underserved populations. We look at cell line samples who don't reflect the population with the greatest incidence of the disease. And then you go create a therapy, we've got a solution, and then you go do your clinical trial. And then you get the post-market analysis. And you're like, oh, the Black patients are getting sicker or the Hispanic patients aren't showing an effect. But if you don't think about this at the beginning, then you are trying to play catch up. That's only if you care at the end about those patients. But if you thought about this concretely from the beginning and did risk prediction and risk stratification early, you would account for these things.
Let me just chime in on that, if you don't mind, because there was a recent report that came out of BBC that looked at people of Zimbabwe and the use of their databases or their genomic databases. And it was used to build AI, not only models, but look at predicting health outcomes. And so recently, Zimbabwe rejected a U.S. healthcare deal that provided $367 million in healthcare funding, right? But the president of Zimbabwe called it a lopsided deal. He says, I'm not taking this, right? You want us to provide biological samples for research and your commercial gain, but you're not willing to share the benefits, if you will, for our own future medical innovation, vaccines, or treatments. And so the negotiation was rejected. He rejected a $500 million deal because he asked some critical questions. He says, what are you going to use for the data? What are you going to use the data for? Excuse me. What are you going to use the data for? Right? And how will the people of Zimbabwe benefit from it? He was willing to walk away, but that's courage. And I think that was the courage to really say, I know the use and I know the potential, but we want to be included in the process in a way that's fair and equitable.
And that's so valid, right? Walking away to make sure that the people get what they need.
That's right.
Thank you. Thank you all for that response, and especially Dr. Manley for helping us understand how AI is advancing within healthcare innovation and research. And what we're hearing from you all is that these technologies are already shaping how healthcare is delivered and how risks are identified and how decisions may be made. And at the same time, your comments raise an important question, which is, how do we responsibly share health data for research and innovation while also being good stewards of our communities' information and ensuring that our communities have equitable access to the benefits that come from that data? So situations like the Zimbabwe example you provided, which to our audience, we've shared that example in the chat, a link to that. They highlight how these conversations about data ownership, access, and fairness are becoming increasingly important. And these are exactly the type of issues that we plan to continue exploring in future conversations throughout this digital fireside chat series. So with that being said, before we move further into the conversation, we'd like to pause for a moment and hear directly from our audience. We've added a link to the first poll question in the chat. And the question is, how comfortable are you with artificial intelligence being used to make your healthcare decisions, such as screening recommendations? Please take a moment to select the option that best reflects your perspective, and we'll give everyone about 20 seconds. All right. Thank you for participating. We will display the results on the screen. So as you can see, our highest answer was about 50% said that they were somewhat comfortable. Again, thank you, as this feedback helps us continue the discussion and plan future conversations in this series. So now let's turn our attention to a specific area where AI is rapidly evolving, and that's cancer detection and screening. We're seeing more advanced AI technologies being used to identify or detect the presence of cancer earlier in the diagnostic process. From your perspectives, how is AI currently being used in cancer screening, and what opportunities exist for these technologies to help identify individuals who may be at higher risk? And Dr. Manley, will begin with you.
How about I unmute myself before I start talking? So, like I said, we'll expand on the example that I used about the lung cancer and nodules and low dose CT. While we know it can flag nodules, it's still a decision support tools. There are a lot of companies that are developing software to look at nodules and say, okay, can you predict the risk? But there still needs to be a follow up with the radiologist on analysis, size of growth over time, and risk assessment. The other big thing I want to talk about, which is maybe the last 10 years or so, is multiplex imaging. And the easiest way to describe this without getting technical jargon is normally when we stain tissues, we have maybe 1 to 2 antibodies we can stain for a slide for clinical lab CLIA. I don't even know what I forgot what the last 2 letters in the acronym. So if one of you know it, you can say it. But you have these certifications that by standards that you can use to stain tissues. But the problem is when you get many tumor samples from a patient, you have very limited amount of tissue and you don't have many ways to stain. So multiplex imaging is a way that allows you to use fluorescent antibodies to proteins. So they have you can put different colors on these proteins that are in the tissue. So you can put up to 4 colors at a time. You can stain that tissue, capture the image, remove the fluorescent color, add another 4 antibodies with the same 4 colors, and you can do this sometimes up to 10 to 20 rounds. So this would allow you to stain up to 80 tissues in 20 cycles. So then this would allow you to look at the cell changes at individual cell level, and then broadly in that tissue architecture, look at changes in tumor progression, tumor phenotype, response to therapy, response to therapeutics, if resistance is being set. And then you can also look at immune markers and all these other markers. So it's a great improvement over what we have, but it's still not completely CLIA certified. But some companies have these machines, but it's like every innovation, every company has a different software and a naming system. So you can't really read between the systems. So that has still always been the big challenge. Whenever we do something new, every company, well, this is our approach. You have to buy our device and our instruments, and we're not going to share. And then the people that lose are the people that are really doing the research and trying to impact patient outcomes.
Thank you, Dr. Manley, for helping us understand, the more technical side of how these tools can really detect cancer earlier. Ms. Dockery, from an access and tech company perspective, how are you seeing these technologies influence screening and early detection?
Before we move on, I want to actually jump back up because I think there's a question in the chat that I wanted to address. So from Dr. Deason, it says, my question is, will AI accelerate bias in medicine? Only if we let it, right? It learns from existing healthcare data, which already has gaps. So unchecked, it scales those disparities. So I think that it takes all of us to create that non-acceleration. So thank you for that question. So back to you. AI's cancer screening are already being used, right? So mammograms, reading mammograms, analyzing pathological slides that Dr. Manley was talking about, flagging early signs of lung and colorectal cancers. And then in some studies, they match or outperform radiologists' accuracy and can do it in a scale that no human team can. The opportunity is real, but access is everything, right? We can't miss out on that access. Right now, these tools are largely being built and deployed in well-resourced hospital systems. The communities carrying the highest cancer burdens, including Black and Brown communities, are often the last to see the benefits. So, Black women like myself, we're already more likely to be diagnosed with breast cancer at a later stage. And AI tool that exists but isn't accessible, that doesn't close the gap, right? To me, that widens it. So things that device and technology companies can do, they control it, right? They control how these tools are built, what populations they are tested on, and where they're sold. If the business model doesn't prioritize underserved markets, the technology simply won't show up there. And that's not an accident. I hate to say it, it's by choice. So the opportunities, getting those tools in communities, health centers, federally qualified healthcare centers, and not just major academic hospitals. I'm requiring AI screens to be validated on diverse populations before they're approved and deployed, and then holding device companies accountable for where their technology does and doesn't go. The technology can save the lives. It's the question is whose lives is it actually being designed to save?
Exactly. Thank you, Ms. Dockery, for highlighting how access and technology deployment can shape who benefits from these innovations. Dr. Covington, building on what we've heard so far, can you expound on how early detection and screening technologies intersect with the broader realities of healthcare access and cost?
Absolutely. First, I'd like to say bravo, Ms. Dockery. You are spot on that last response. And I just like to add by saying that the cost of care, not only to treat it and to manage it, is high and is unreachable potentially for those who do not have the healthcare insurance or the right kinds of healthcare coverage. And so when you then think about someone prioritizing getting screening, like breast cancer, prostate cancer, cervical cancer, colon cancer, you also have to think about the burden. Now, I may bore you just for a second with some details in terms of cost, but I think it's important and it's impactful. The National Cancer Institute reported in 2019, really, that the economic burden of cancer was projected to be $21 billion. That's with a B. And this is not only emotional, but it's also impactful in that the economic burden represents emotional, physical, financial, organizational strain that people have as they manage their healthcare needs. So when you think about the cost, and this is not including the out-of-pocket costs, so what you spend, particularly the stage of cancer that you may be diagnosed with, or time management, but this is tremendous. And so when we then think about resources, and there are compassionate care organizations, like you have drug companies that may provide compassionate care, or you may have companies like the PAN Foundation that helps people with their financing of healthcare, but it disproportionately impacts those who are not only in communities, but those who are diagnosed in later stages. So these direct medical costs, if you will, are expected to grow tremendously in 2030. There's expected to be a 37% increase from 2020 to 2030. That's to nearly $259 billion. Of course, that's due to demographic changes and better management of care. But a study that reinforced this was published by Moriato and her colleagues in 2020, and it took data from the SEER database. And those who are in cancer will know that that's a database that has all sorts of complex information and detailed information. But they looked at the yearly cost, and it showed us that the yearly cost of care for cancer is $42,000, and the end of life care for cancer is something like $105,000, and so on average. And so this doesn't include drug costs, but we can see that there is an increased cost to society. And when you add in indirect costs like productivity or quality of life loss, it even rises faster. Now, I'm not quoting these numbers to be impressive, but I am saying it as a wake-up call. Diagnostic devices, diagnostic interventions, as well as treatment are good because they help us to get to cancer earlier in the process, and that can save lives, and it is also cost effective. So I'll stop here and I'll give it back to you, Shatana. But again, this is a wake-up call for us to really understand not only the importance of the innovations, but making sure that it's getting to people who need it most.
Thank you, Dr. Covington. And those numbers really highlight the broader impact that cancer can have, not just on individual patients, but on families, communities, and the healthcare system as a whole. And they reinforce why early detection and screening are so critical. So, while we've been discussing the emerging role of AI in improving detection and diagnostics, it's important to step back and look at where we currently stand with cancer screening more broadly, again, particularly within Black communities. In other words, what progress have we made and where do meaningful gaps still exist? So, our next question focuses on screening successes and ongoing challenges. Dr. Covington, from your experience working closely with communities and health initiatives, what have been some of the biggest successes and ongoing challenges in cancer screening efforts within the Black community?
So there have been many interventions and many things that are going on in various communities, but Agape Strategic Solutions is currently conducting an exploratory analysis looking at consumer discovery, understanding the attitudes, the beliefs, the perspectives about early colorectal cancer in particular, right? And our goal is to look at not only the patient journey, but to begin to test the hypothesis that help us to inform how do we not only build these digital tools, how do we build engagement processes, and how can it be scaled in oncology? I'd like to do a quick shout out to my colleague Zanab, who has done excellent work on this project as well. So I thank you, my friend. But what we're doing is we're examining another consumer archetypes, if you will. And what we want to do is we want to better understand how screening earlier, especially for those who are younger in age, before 45, because we know that it's trending earlier, how are they thinking about not only screening, but colonoscopies and other kinds of interventions to treat colon cancer? And so it's clear from the interviews that we have done that a lot is going on, not enough, but a lot is going on that's trying to understand younger candidates. What are the issues that are barriers to screening for them? What will motivate them to get screened earlier, even before symptoms emerge? And so we're specifically asking people in the Black community and in rural areas, research constrained areas, about their perspectives on screening and treatment. The last thing I'll say is this. We've been getting some early insight, all right, about the motivations and the gaps for especially this younger age group or younger population. We're finding that the issue of trust in the healthcare system and having these concordant conversations, if you will, is extremely, extremely important. So regardless of the kind of screening tool that's used, it's also very important that we have the kinds of conversations that will help people understand not only what's being used, but also to be able to understand the outcomes of those kinds of tests.
Thank you, Dr. Covington, for sharing those insights from your research. And it's really helpful to hear how communities are thinking about screening, trust, and conversations with providers as we move forward. Ms. Dockery, from your perspective, working closely with communities and technology organizations, what have been some of the biggest successes in cancer screening efforts, and where do the gaps remain?
I think we've seen progress, and I think that's important. Awareness has grown. Community health workers, faith-based organizations have moved the needle on screening, and those screening rates over the years have increased. And that's not a small feat. So I want to say here, like, that's significant, right? More people are getting screened, the more people that need to get screened. Let's talk a little bit about colorectal cancer. Black Americans are about 20% more likely to develop colorectal cancer and about 40% more likely to die from it than their white counterparts. So some of that research includes screening a little bit younger. So what I think the ongoing gaps is knowing you should get screened and getting screened, right? There's two different things. So cost, time off of work, transportation. There's so many reasons why people don't get screened that should get screened. Even when you talk about the PrEP, right? It scares people off. Primary care access is uneven. So even if you don't have a consistent provider who knows your history and follows up, your screening falls through the cracks. The biggest success, which I think you asked me, is have come from meeting people where they are, trusted messengers, and reduce barriers. And I think that's important for everything, like meet people where they are. And the biggest challenges are the ones that exist outside the exam room. So those access, the economics, and healthcare systems that still has to earn trust that it always haven't deserved.
Yes, thank you, Ms. Dockery, for highlighting both the progress that has been made and the structural barriers that still exist outside of the exam room. We call them, those social determinants of health that a lot of people don't necessarily think about or consider that have just as much of an impact as what's happening inside the exam room. Dr. Manley, from your perspective in biomedical research and public health data, how do these successes and gaps show up in other screening areas such as lung cancer?
Can you hear me?
Yes.
Okay. So lung cancer is like the leading cause of cancer death in the US and worldwide. And we know that Black individuals are 13% less likely to be diagnosed early, 19% less likely to receive surgical treatment, and 13% less likely to survive 5 years compared to white individuals. The original US Preventive Services Task Force guidelines were aged, you had to be 55 to 80 with a 30-year packed history of smoking or have quit within the last 15 years. And looking at some of that data, Black individuals did have much better early detection when they were looked at a subset of the data. But overall, there was resistance to move the guidelines down solely for just the Black population. So they ended up having to move the guidelines down to everyone. So now the new guidelines say 50 to 80 year pack, 50 to 80 years of age, 20-year pack history, and currently consuming or have quit within the last 15 years. So this allows us to capture more Black people who show up with later stage disease. And part of this is due to differences in metabolism of nicotine and of menthol and cigarettes, which makes Black people smoke more. I have this misplaced notion that menthol is better because, oh, well, they're better because when menthol has this cooling effect when you inhale it. So when you inhale menthol cigarette, it masks all the searing heat from the tobacco. And so we have a lot in our community that believe, well, they're better. No, they're actually much worse. It's just makes it much harder to see that. So we really need to have the gaps are like just educating underserved communities. Stigma and nihilism are real. We need to have community engagement from these centers that look like people from the communities they serve. Trials should reflect the communities they serve, not just show up, hey, we want to do a trial here, get the data, maybe report it to you, but then you'll never hear from us again. And we'll treat you well while you're on the trial, but don't come to the hospital if you need any other intervention, because then you're going to get treated like detritus. So we have to take into the account the other external factors impacting Black people's ability to get care and get to the clinic, which we don't often take into account.
Thank you, Dr. Manley, for helping us really understand how changes in screening guidelines and better representation in research can directly impact outcomes in underserved communities. So thank you to our panelists for their insights thus far. We have now come to our second poll question, and we want to better understand your thoughts about barriers to cancer screening as a preventive measure. So our next question is, what do you believe are the biggest barriers to colorectal cancer screening? And please select all that apply. And again, we'll give everyone another 20 seconds. All right. So thank you again for your feedback. We are seeing that one of the highest is fear of results, right? So we know that people on this call, the audience, one of their biggest barriers to colorectal cancer screening is fear of the results. So now we will move on to our final two discussion questions. As we think about the future of screening, AI may offer new ways to identify risks earlier and reach people who might otherwise fall through the cracks. Ms. Dockery, from your perspective, working at the intersection of technology and community access, how might AI help improve earlier colorectal cancer screening and outcomes?
I think it all depends on the data, right? If the models aren't trained on the population that reflect the Black patients, the predictions will be less accurate for us. And if the tools are only deployed in systems where Black patients already have consistent access, we miss the people who need it the most. So I think that just sums it up. The technology is promising, but it has to be built right and deployed intentionally to actually change outcomes for our communities.
Thank you, Ms. Dockery. Dr. Manley, from a research and data science perspective, what should we be thinking about when developing these AI models to ensure they are accurate and equitable across different populations? I think we might have lost Dr. Manley.
All right, no worries. I can jump in while we wait back for him. And I agree with what's been said. There are different ways in which people can be screened, right? So when we talk about early screening in particular, we can look at if blood is present in stool. We can look at if there are chemicals that are used to detect blood in the stool. We'll look at DNA tests to look at DNA markers. We can have blood that's drawn at the time of an office visit. We have virtual colonoscopies, if you will, that use x-rays or computers to look at the colon, or we can look at colonoscopies and other more probing techniques, right? So the point is that we have these AI technologies that can identify certain kinds of cancer and certain kinds of treatment across patient populations. So we have to have open and honest conversations that are evidence driven. People want to understand not only what their options are, but they also want to understand what's affected. They want to understand, will I have access to this given my insurance? What are the out-of-pocket costs? What happens after screening? You just saw a poll that says that many are concerned about the results. And so digital engagement techniques, let me stop, I talk really fast, y'all. Digital engagement tools, let me slow down, as my mother said, can, an in-person connection, as Ms. Dockery said, can be reliable ways to not only train, but inform community and community lay health workers. Promise you, I'm going to slow down on the types of innovations that can be more trusting and also much more transparent as we have these kinds of conversations. Dr. Manley, you back? You back on? Go for it, brother.
We thought he was back on, but I don't think he's back on. So we'll come back to Dr. Manley in our next question. So thank you, Dr. Covington and Ms. Dockery, for answering that question. Moving on to our final discussion topic, we want to focus on an important issue that often comes up when new technologies enter healthcare, which everyone has talked about thus far: trust, communication, and community concerns. So moving into our final question for the panel, what concerns about AI in healthcare should be discussed within the Black community, and how can people have informed conversations about these tools with their providers, families, and communities? And Dr. Covington, we'll begin with you.
Thank you so very much. Go ahead, Eugene. You have it. Go ahead. Go for it.
All right. It's me. Okay.
You go.
So I'll talk about AI in general. So many of, our models are developed on European populations, and whether it's cell line studies, genomic studies, or clinical trials. And so if our training set and test data set do not reflect either the populations at greatest risk or the demographics of the country where the study is being implemented, then it's not likely to be predictive in those communities. So it requires real due diligence and representation on teams at the start of the design of these approaches to mitigate potential biases that will show up. Because once we wait to the back end, it's too late to go and correct it. Then it may become more costly, or it's then, well, we don't have money for it. It's like, well, then you should have thought about this ahead of time.
Got you. Thank you, Dr. Manley. Back to you, Dr. Covington.
Okay, just very quickly, we have been conducting research that we call pulse surveys. We did one in 2023. This is People Empowering People for Inclusion Now. We did one last summer. And what we're finding is that we have a publication that came out in DIA Global Forum. But what we're finding is, especially from the latest research, is that there's a correlation between those who have good relationships, for example, with their healthcare providers and whether or not they want to be in a clinical trial, or those who have high correlations with their providers and wanting to have more trust in the healthcare system. So we understand that these conversations and transparent conversations are very, very important. I'll stop there.
Thank you, Dr. Covington, for emphasizing the importance of having these conversations really as the first step to building that trust and beginning to have conversations about the issue. Moving on to Ms. Dockery.
And I think it's just the same for us having the conversations, right? Understanding what AI is, asking these questions, asking your healthcare providers, what are you doing? How is AI playing a part of my care today?
Perfect. Thank you, Ms. Dockery. Short and sweet, but very much to the point. So now we've come to our final poll question. So as we think about solutions, we'd love your input. Our final question to the audience is, what factors would improve the participation in colorectal cancer screening in your community? And again, you can select all that apply, and we'll give everyone a final 20 seconds.
It's really helpful. Thank you.
All right, thank you. So as we can see from the poll, we have the highest are education about screening options, stronger provider recommendation, and community outreach programs. So as we wrap up today's discussion, we'd like to leave our audience with a few key takeaways from our panelists. So for our closing segment, I'll invite each of our speakers to just a brief 20-second one message that they would like the community to remember as we think about colorectal cancer screening and the evolving role of artificial intelligence in healthcare. And we'll start with Ms. Dockery, then Dr. Manley, and end with Dr. Covington.
I think my 20 seconds is going to be the same. Ask questions, get screened if you can, provide, look into things that will make sure, take care of your health. So always prioritize your health the best way you can.
Thank you, Ms. Dockery. Dr. Manley? I think we lost Dr. Manley again. Dr. Covington, do you want to step in?
I will, and I'm looking at the comments from Lisa Collins, and I would agree. We have to be able to scale this to other places globally, if you will. And those who are conducting research, those who are building innovations and those digital tools, they may be smaller organizations. They may be organizations that you haven't heard about, organizations you haven't been working with for the last 15 years. And so to have not only these trusted conversations from people who are credible and organizations that are credible is going to be important. The costs are too high and the burden is too great for us not to take a more integrated, I think, approach in the process. Handing it back to you, Dr. Manley, to close us up, if you will.
So we're talking about the role of AI in healthcare delivery, right? We're up there.
Yeah, you're wrapping it up with your conclusion.
Understanding what data does and doesn't work and what it doesn't contain will help us deliver or hinder care delivery. So we always need to ask who's included in the data that will help us come up with recommendations and or guidelines. And if we don't have it, then we can't be effective.
Perfect. Thank you, Dr. Manley. And I want to thank each of our panelists, Dr. Manley, Ms. Dockery, and Dr. Covington, for sharing your expertise and perspectives today. Again, conversations like this are important because they help bridge the gap between emerging technologies and communities they ultimately serve. As artificial intelligence continues to shape healthcare, it's critical that communities are informed, engaged, and included in the development and use of these tools. I'd also like to extend a special thank you to Zainab for her partnership on this project with Agape Strategic Solutions, including her technical leadership and support behind the scenes during today's session. She's been putting all of our links in the chat for us. And as we conclude, you'll see a QR code on your screen, and the survey link will also be posted in the chat. We invite you to take a moment to complete our brief post-webinar survey. Your feedback helps us improve and shape future conversations in the Digital Fireside Chat series. And then lastly, I'd like to thank you all, our audience, for joining us and participating in today's discussion. We appreciate you spending this time with us and hope you'll join us again for future sessions. Have a great rest of your day, everyone.